Good evening to everyone present here with us today. This is Priyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned Professor Dr. Arpandev Bhattacharya. Sir is MBBS, MD General Medicine, DM Endocrinology, DNB Med, MRCP, CCST Internal Medicine Endocrinology, FRCP Consultant Endocrinologist at Manipal Hospital, Bangalore. Professor Sir is also a professor of endocrinology at JJM Medical College. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is diagnosis and management of subclinical hypothyroidism. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you. Thanks very much. Hello, everybody. Now we are going to discuss on the topic of subclinical hypothyroidism, diagnosis and treatment, when to treat, when not to treat. At the beginning, there are good and bad news. The bad news is that I have a cold. I'm still having a bit cough. But the good news is that this is a virtual platform, so I can't infect you, any one of you. So around 25 minutes or so, I think I'll take you this topic, and we'll interact. Whatever is your opinion, comment, experience, we can share. It's a little bit of a disclaimer at the beginnings that I do not have a share in the pharmaceutical industry, and please be ready to listen my understanding of the topic, not what guideline says, because that's can easily available now in our smartphone only. I do take the responsibility of the text of my talk, but I will suggest 5-star points that this should be considered as a take-home message. Okay, this is what I want, absolutely clearly to the point, and this is what I don't want. And this is a French, naturalized French physicist who once told, before I came to this meeting, I was confused. But after attending, I'm still confused, but on a higher level. I hope none of the delegates will leave this meeting in this concept of confusion. This is our approach to a patient of thyroid disease. This is what been incorporated in my brain, my teacher, and I think more than 30 years back, I think this is the best way that you can approach the patient with thyroid disease. First, we need to think of the functional aspect, then anatomical aspect, then etiological aspect. Function of thyroid gland is to produce thyroid hormone. Whether it is producing normal, euthyroid, low, hypothyroid, high, hyperthyroid. For this, we do the clinical examination, then we do the blood test. Anatomical, irrespective of the function of the thyroid gland, what the size of the gland is doing to you. If it is a big, whether it is putting a pressure on the trachea, pressure on the recurrent laryngeal nerve, pressure on the food pipe, in the supraintestinum, and we do different clinical tests and investigation, mainly imaging, X-ray, scan, barium, swallow, and so on. Thirdly, what is the reason for this patient has thyroid problem? We have some clinical features like an infiltrative eye disease for Graves' disease or dermopathy for Graves' disease. Then we do different tests, including antibody, ultrasound scan, isotope scan, histology, and so on, to find out what is the reason for this person with thyroid disease. So for today's talk is concerned, we presume there is no goiter. Okay, if you have a big goiter, whether your TSH is 8 and 11, that will not be the question asked, isn't it? So for our discussion of subclinical hypothyroidism, there is no goiter. So anatomical section is out. And also, it's a benign disorder. We are not going to talk a follicular carcinoma of the thyroid. What do you do with the TSH 7.1? Correct? So we are not talking any malignant pathology. It's a benign pathology. When we tell subclinical hypothyroidism, we mean there is no significant clinical goiter. It is a benign pathology, and we are here, subclinical, before the clinical symptoms. So by definition, there should not be any symptoms on the sign. Subclinical. So quickly, let's see that. If I can put my laser pointer. Yeah. So this is a slide which I made for the teaching purpose nearly 30 years back. I still show this slide. So x-axis is the thyroid hormone. This is the normal. This is high and this is low. Y-axis is the TSH. This is normal. This is low and this is high. So we expect normal person will have a normal TSH and normal thyroid hormone. Okay. We are expect to get the blood report biochemistry here. Now, in subclinical hypothyroidism, in primary hypothyroidism, your thyroid hormone will be low and the TSH will be high. But in subclinical hypothyroidism, what we are talking, our thyroid hormone is normal, but TSH is high, little high. How high? We'll come to that one. A raised TSH with a normal thyroid hormone. This is the definition of subclinical hypothyroidism. And I told already, we are not expecting any clinical symptoms or signs of hypothyroidism. So this is a purely a biochemical diagnosis. Subclinical hypothyroidism, purely a biochemical diagnosis, and this gets my first star. Okay. So no symptom of hypothyroidism, a normal thyroid hormone with raised TSH. That's our diagnosis. Now, now you looked at how sensitive and the specific are the symptoms of hypothyroidism. Very important to see. For example, these are the top 10 symptoms of hypothyroidism: weakness, dry skin, lethargy, puffiness, cold interest, dull, pituitary, weight gain, hearing, hoarseness, and so on. 10. And this is the sensitivity. What does that mean? If you find 100 patients of primary hypothyroidism, 96 of them will complain of weakness. 77 of them will complain of dull face. 54 of them will complain of weight gain. 34 will complain of hoarseness of voice. This is primary hypothyroidism, overt hypothyroidism, not subclinical. But now, interesting, look at the specificity. This is the specificity. What does it mean? In simple term, clinical term, if we see 100 people in your medical OPD who comes with a weakness, only 2 will have overt hypothyroidism. If you see 100 people complain in the medical OPD, only complain of cold internals, only 10 will have overt hypothyroidism. So what I try to tell is that symptoms of hypothyroidism are very sensitive, but least specific. On top of that, I'm talking you that subclinical hypothyroidism, no symptoms. So this is very interesting medical science. So this is what a patient, the person has no symptom, a routine check, thyroid function done, T3 1.3 nanogram, normal level 0.8 to 1.8, T4 10.1 microgram per DL, 5 to 12 normal reference range, TSH 7.7, 0.5 to 4.5 milliunit per liter. So we have raised TSH with a normal thyroid hormone. That's our definition. If you remember the first slide of the table, it is a hypothyroidism. Now there are certain conditions that total thyroid hormone increases, but free thyroid hormone is normal. They call euthyroid hyperthyroxanemia. They're euthyroid. For classic example, in pregnancy, people taking oral contraceptive pill, people with a biliary cirrhosis. And opposite that also true that sorry, people have a decreased total thyroid hormone with a normal free thyroid hormone. Like patient losing a lot of protein, nephrotic syndrome, or people who are on steroid. So to reduce this confusion of total hormone, it is better to check the free hormone. So test we'll recommend to do is TSH and free thyroxine. Free thyroxine is done in the unit of nanogram per DL. The normal is 1 to 2.1. This is around 1.4. So this person has a TSH of 7.7 and free T4 in the normal, mid-normal range. It qualifies for the diagnosis of subclinical hypothyroidism. We do not need free T3 for diagnosis of subclinical hypothyroidism. So it is TSH and free T4. Now, if you see this now, this is a publication nearly 10 years back from the Amrita Institute of Kochi, that in India, in the routine community survey, 9% of the people in that survey, number of surveys nearly 1,000 patients, had subclinical hypothyroidism. Just to give you the prevalence, and if it's the male female, so it is ratio is around 1:2. Not necessarily that this has to be right for everybody's study, but this is what our country data, we should know a bit of it. So let's pick up four clinical scenario. You and me are clinician. We are going to see patient again tomorrow. Not tomorrow. Tomorrow is Sunday. Monday. So if the patient comes, what are you going to do? So this particular person, as you see, this is a man of middle-aged man with a quite good amount of abdominal obesity. There is no symptom, no goiter, routine blood check done, TSH 7.7, free T4 1.4, subclinical hypothyroidism. The question is, should we treat? Or this person, this girl, who is 14 years, came with a poor growth, not matured yet, height is of 8 years, so short for age. Height is 8 years, chronological is 14 years. Thyroid function test done as a workup for short stature. She showed TSH 7.7, free T4 1.4. Purposefully, I am keeping the level normal so that there is a less confusion. Okay, should we treat this girl or this lady who is pregnant at 29 weeks? Again, thyroid test done routinely. There is no symptom. TSH 7.7, free T4 1.1. Should we treat? Or this boy who is barely 4 years, there is no symptom, but there is a small goiter. Seeing this, the pediatrician has done a thyroid function test which showed TSH of 7.7 and the free T4 is 1.4. Should we treat? Now, look at from the other side. If we don't treat subclinical hypothyroidism, what will happen? Okay. Now, they will progress to overt hypothyroidism. That's okay. Around, say, 5% per year. They will do overt hypothyroidism, then we will treat thyroid. This is one. Now, cardiac dysfunction, including congestive cardiac failure, I will be coming last 3-4 slides, is a very important point. That can get worse if we do not treat. Cardiac advanced like angina, MI, cardiovascular accident, all this little bit plus minus data is there, but certainly we know that cholesterol goes up, particularly LDL cholesterol, and which know that which will be more risk for atherosclerotic cardiovascular disease. We have some data to suggest that neuropsychiatric symptoms can be a bit more prominent if you leave subclinical hypothyroidism untreated, and we are very aware that fertility time, we need a good amount, good dose of good normal thyroid function to have a successful fertility conception on the pregnancy. And this is the thing will happen if we do not treat subclinical hypothyroidism. Do not treat. Now see that one strength of association. I am going to tell you that. So two category, TSH more than 10. 10 is the cutoff value. First slide I told you, but I'll tell you the cutoff. This is the 10. 10 is more than 10. We think overt hypothyroidism we should be treated. But 4.5 the 10, this is by definition or subclinical. So progression of hypo, there are good data. Cardiac endpoint, actually there is not much good data. LDL cholesterol, fair enough data for primary hypothyroidism, overt hypothyroidism, not much in the subclinical hypothyroidism. Symptoms, already I told, neuropsychotic symptoms, this is not much big data is there, although we keep on telling this. But so, as a consequence that the benefit of treatment, if you treat subclinical hypothyroidism, your progression of hypo will certainly reduce. But so for the cardiac endpoint concern, LDL concern, not much of this of value is this. Neuropsychiatric symptoms, not much data is there. This is what you need to remember very, 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 very carefully before you start the treatment. Now, you start the treatment, what can happen? Subclinical hypothyroidism, we are treating with thyroxine. We will produce subclinical hyperthyroidism if you are not careful. And this is real chances 14 to 21%. That is all 1 in 5 patients. If you start treating 100 patients of subclinical hypothyroidism, you are not very careful, 20% of them you will produce subclinical hyperthyroidism. So thyroid hormone high, TSH low. And we know the consequence of subclinical hypothyroidism, so-called the atrial fibrillation is concerned and osteoporosis is concerned. Then the question is, are we really treating for the benefit? What is the benefit? Treatment is not costly. Treatment is cheap, but the tests are certainly costly. And that's what the whole debate all over the goes over subclinical hypothyroidism when to treat. If you see the benefit of treatment, progression to the overt hypothyroidism reduces, symptom reduces, LDL cholesterol, probably yes. Heart failure, some data, stroke cognitive function, some data is there. Again, the strength of association, is somewhere strong, somewhere is weak. But it's okay. We agree that certain situation need to pick up certain situations where we need to treat. Now, this is a very interesting. Again, is my own conceptual slide. In the x-axis is 0 to 10%. We are talking about evidence-based medicine, and y-axis 0 to 10, 100% experience-based medicine. If you the only evidence-based medicine, you will be here difficult. If you see only experience medicine, only listening to the teacher what they told, you are following, you are completely ignoring the current medical advancement. Again, it will be difficult. We need to make some sort of a balance. Where is my slide? Is not moving away. We need to some sort of a balance to see where we stand. 1 minute. My slide is not moving. Why? Okay. This is what the balance I mean to say. We need to take the experience, but we need to also see in the evidence. And this brings to the feature of your um, this brings to the this brings to the feature of the so-called the guidelines. Now, before you see what the guidelines tells, as I told, I'm not going to tell you the guidelines. Hierarchy of evidence-based medicine. Level 1, clear evidence from randomized control trial or meta-analysis. Level 2, supportive evidence. Level 3, supportive evidence. Level 4, here our guideline and consensus guidelines. So basically, when you are talking about any guideline tells like that, we need to remember in the hierarchy of evidence-based medicine, that's rubbish. But big people talks, so we need to listen. So this is what American Thyroid Association guideline consensus statement. TSH should be 10, should less than 10, should be tailored to the individual patient. Consider symptom, positive antibody, AS severity, TSH more than 10, treat. That we know it. That's fine. Nothing new we learn. European Thyroid Association, TSH less than 10, younger patient, trial period of LT4 can be given. Older patient, careful follow-up, avoid LT4 treatment. TSH more than 10, you treat. That's fine. We know that. British Thyroid Association. Screen when absolutely necessary. Wonderful, practical. Because in UK, it is NHS, National Health System, National Health Service. So whatever test done, government pays. So if you start doing whole population test, government cost will go up, and then follow-up cost will go up, then treatment cost will go up, then consultation cost. So very intelligent British people as usual. Screen when absolutely necessary. Okay, raise TSH, positive antibody, over hypothyroidism more, only modest benefit of the treatment. And this is our Indian Thyroid Society guideline, the last one, I think 2022. Recommend treatment, actually it makes some sense, and it is a clarity is there. Recommend treatment, TSH more than 10, agreed, everybody agrees, that's over hypothyroidism, no question. But patient with infertility, high titer of antibody, goiter, cardiovascular risk factor under the age of 70 may be candidate for therapy. It makes some sense, which we'll talk to it. So if you come to this gentleman, should you treat or not to treat a subclinical hypothyroidism, I probably will treat if the lipids are abnormal. If I do with this patient is a classic patient to get a lipid profile. If you find the lipid profile is normal, I'm not going to treat. I'll just observe it. This girl certainly qualifies for treatment. No doubt about that. No chance of taking risk. This lady, again, certainly qualifies for treatment in pregnancy. Okay? And just to take a bit further, this is our normal, this is primary hypothyroidism, this is subclinical hypothyroidism that we are treating. Why we need to treat this? Because gestational hypertension, 1 in 3 in comparison to 1 in 12 in general population. So subclinical hypothyroidism has chance of gestational hypertension, which is more than 5 times the general population, more than 3 times chance of placental abruption, more than nearly 2 times chance of preterm labor. Little oldish data, 19 years old, but these are true, and this is the indication that we should be treating. And this boy certainly will treat. Okay, this is likely to proceed to overt hypothyroidism. So if you are treating, what is the treatment? The goal of treatment is restore the TSH level to normal with free T4 in the normal range, reference range. Initial dose always you start at the 25 microgram. This is again experience based, not no evidence. Caution in cardiac patients, sometimes rarely we start with the 12.5 as well. Monitoring, first blood sample should be done between 4 and 6 weeks. Again, sample should be TSH free T4, no confusion, no extra test. Target, high normal free T4, low normal TSH. This is interesting. So our target, the biochemical target should be low normal TSH with a high normal free T4, which means this in the normal range, we will try to keep the blood level here, which should be low normal TSH and high normal free T4. Okay, that's the supposed to be the best benefit, and this has evidence, clear evidence in pregnancy. There are studies from Scotland which showed that's the best one. Level for the baby's growth and development. Okay, this is my second star. Now this is what the algorithm I tell is AB's algorithm. AB is me only, not Amitabh Bachchan. So elevated TSH is less than 70, detailed history, recheck TSH, check free T4, fit of normal. If the TSH is more than 10, treat. TSH less than 10, special situation present, treat them. I told you the special situation, like in pregnancy, short stature, children, dyslipidemia. Special situation is absent. Now we need to think, what is the role of the antibodies? I purposefully till now didn't come to the antibody. Now we are talking about two antibodies. One is thyroglobulin antibody, one is thyroid microsomal antibody. Thyroid antibody against the TPO and thyroglobulin against the thyroglobulin. Now the interesting to see is that general population, look at that, up to 20%, up to 25%, they are positive. If your family history, up to 50% are the positive. So whenever you are doing the antibody, you need to remember this. Don't start jump up the TMA titer and TGA titer. Okay, and this is definitely my third star, and I'm very clear what I'm talking here. So you do a positive antibody. You know the positive antibody, the chance of progression toward hypothyroidism is higher, nearly doubles. Then you think of treating. That's why my dotted line I have given, plus minus treatment. Okay. Now, again, the same Amrita data, nearly 10 years old. Subclinical hypothyroidism. If you see the antibody, look at that. In euthyroid, hardly around 10%, all the age group. But when they are subclinical hypothyroid, half of them are antibodies. So if you do an antibody, you will land up treating half of the people who have a subclinical hypothyroidism. Remember that before requesting for the antibody test. And then they try to see the iodine status. So iodine status is very, very important, is that iodine status is very, very important, is that whether it is subclinical hypothyroidism or euthyroid, in the community, there is not much difference. We are talking a lot of low iodine salt, all this thing. It's very, 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 very difficult situation. So that's what my algorithm. If you come, if the ATM antibody positive plus minus symptom, you go think of therapy. If it is a negative, just follow up. Just follow, observe. Maybe around 6 months, 12 months. Okay. And that's my fourth star. Now, this is one of the algorithm. The reason I'm showing is very, very clear here, is that with more or less the same, the TSH thing. Here, one point I wanted to highlight till now, which I have not, again, my slides are got stuck. Sorry, 1 minute. I'll have to go this and this. Okay. See that here. Symptoms of hypothyroidism absent. Okay. My laser pointer. Yeah. Symptoms of hypothyroidism absent. TSH more than 7, less than 10. More than 10, we know we'll treat. More than 7, less than 10. Consider 6-month trial of therapy, less than 70 years. This is what we need to think of, cardiac thing I was talking. And here I'm going to give you a different target. Okay, I'm coming on subclinical hypothyroidism and the heart. And this is what happens. If you see the cardiac event rate, if you see euthyroid and subclinical hypothyroidism, it is much more cardiac event rate. All-cause mortality, much more. It's very clear, no? This is the days of follow-up, 3,000 days, which is a good study. Euthyroid, this is your all-cause mortality. If you're hypothyroid, this is the subclinical hypothyroid, this is called all-cause mortality, irrespective of any other illness. So we need to find a cutoff for the cardiac events, and this is very important. And you see this one. If you have a subclinical hypothyroidism, heart failure with reduced ejection fraction, you know these words very well, and without subclinical hypothyroidism, there is a clearly increased 1-year mortality and readmission rate in the hospital in 30 days. Okay. In the special situation, we have not spoken this. This is very important. We need to remember this. And where is the cutoff? And this is the cutoff. The solid line, TSH 0.1 to 4.4. Okay. So this is the, say, normal. This is a baseline. Dotted 7 to 9.9 there, more than 10 there, and 4.5 to 6.9 there. So if your TSH is less than 7, you are almost like normal. But if your TSH more than 7, you're almost like more than 10. So my cutoff for this type of situation will be 7. And this is what exactly is shown. TSH level 7 to 9.9, and this is a very significant hazard ratio, nearly 2.5 times increased chance of congestive heart failure. So people who have atherosclerotic heart disease, people who have a congestive heart failure, whether reduced ejection fraction or preserved ejection fraction, my cutoff will be 7. This is my 5th star. So that's the 5 stars. Number 1, let us get the definition very clear. Number 2, if you have decided to treat, get to the target. Target, you remember, free T4 low, free T4 high normal, TSH low normal. Number 3, antibody when you are doing, interpret cleverly, and please do not repeat. This is one reason in the clinical medicine they increase the tension for the family and the patient. Last time my TMA was 700. See, this time it has become 930. You are telling my blood reports are very good. TMA titer or comparison 100% will come if you keep on checking TMA. If you are checking TMA at the diagnosis, fine. You please do. But please do not recheck. No value. Nothing will achieve by doing that. Number 4, systematic approach is a must, as always we tell. And number 5, people with atherosclerotic cardiovascular disease and the congestive failure, threshold target, remember 7 TSH. And I'm going to stop here. Thank you for listening. And let me see what sort of question or the comment or your experience you share with me. Madam, I'm finished.
Thank you so much, sir, for your wonderful presentation. We do have some question if you like to take that up.
Yep.
So, sir, the first question from our audience is, what role does TSH and free T4 play in diagnosing subclinical hypothyroidism, and how often should this test be repeated for confirmation?
Okay, diagnosis, as I told very clearly, will depend on the checking the blood test for the TSH and free T4. So we expect the free T4 is in the normal range and the TSH is high. High means we tell upper limit of normal 4.5, most of the laboratory, and more than 10, we tell a primary or overt hypothyroidism. So we are talking between 4.5 and 10. How often to be done? Well, if there is no reason to repeat very quickly, probably 6 months to 12 months is good enough, as long as my person sitting next to me in the opposite side of the table agrees with that. But as usual happen in our corporate hospital or in the metro cities, the people are super anxious. They will keep on doing every 2 weeks or 3 weeks, but probably we don't gain much. But certain situation, for example, somebody trying to conceive or somebody's lipid profiles are not getting better, if you do a bit more frequently, there's nothing wrong. But as long as we are clear what you are doing and why you are doing, I have no problem.
So the next question is, how does the TSH threshold for treatment differ based on factors like age, pregnancy, or the presence of comorbidities?
Well, pregnancy is the same. We will maintain the TSH low normal, free T4 high normal. Age less more than 70 years, we take so-called elderly. The problem is that I think one slide I showed you that 1 in 5 patients there is chance of producing subclinical hyperthyroidism, and if you produce subclinical hyperthyroidism, your chance of getting atrial fibrillation and osteoporosis will be more. So if you are treating elderly people, roughly say more than 70 or 75, we need to be double careful. And also we need to remember that as a normal population TSH, little goes up to the elderly. So you need to be careful thinking that what point you need to start. And here is the classic situation where even you can start less than 25. You can start with a 12.5 microgram, which is easily available. So on the one hand, look at the scientific evidence and scientific confusion. On the one hand, I am telling that people who are elderly, think of threshold and think of be careful, go very slow. And on the other hand, I'm telling is that people with atherosclerotic cardiovascular disease and heart failure, which will happen more in the elderly, you should be treating TSH of 7 when TSH more than 7. So this decision you need to take in front of the patient, explaining the pros and cons of the treatment. And obviously, needless to tell that we have to closely monitor this group of people.
So there's one last question. How frequently should patient with untreated subclinical hypothyroidism be monitored, and what parameters guide should follow up?
Okay, very, very good and clear question. So our parameters is TSH free T4. There's no doubt about that. How frequently? As I was telling, probably 6 months to 12 months is okay. But most of the people come with this, they get anxious. They will not wait for 6 months. So we tell to do one test around 4 to 6 weeks time, and then we have a two value, so we can see which direction it is going. So
Thank
that's
you.
more or less. First time you do 4 to 6 weeks. After that, probably 6 months.
Thank you, sir, for answering all our questions. That's all from our audience, sir. So, sir, before concluding, any take home message from your end?
Well, my take home message will be very, very clear. Subclinical hypothyroidism, there is a specific subset is there that we need to treat them, and it is all our duty that we pick up the correct people, treat them correctly, so get the best benefit of it.
Thank you so much, sir, for joining us today. With your permission, I would like to conclude today's session. Thank
Thanks,
you.
thanks very much. Well,